Hello, my name is Winnie Barawa and welcome to our today's session where we're gonna go through what we call respiratory system assessment. So if you're new into this place or this channel, this is Medic Academy where we discuss different areas of health covering different specialties including diseases, experts, and even different tips on how to handle the health arena as a so first, before we go direct into analyzing the assessment or checking how to assess the respiratory system, it's good to review the anatomy of our respiratory system. So in basics is that the respiratory system is made up of the following organs. So we start off with the nasal cavity here, so called the nasal cavity, which after the nasal cavity, which we commonly refer to as the nose, we move downwards into the pharyngeal area, and the pharynx, just a reminder, is made of three areas, and that is the nasopharynx, the oropharynx, and the laryngopharynx. And after the pharynx, we are able to access the larynx, which is our voice box. And then we go to the trachea. From the trachea, we divide into two branches of the bronchus, and that is the left and the right bronchus. And the bronchus gets to access our lungs. And in the lungs, we have different category of lobes, whereby on the left lung, we have two lobes, and on the right lung, we have three lobes. So within the lobes, our bronchus divide further into smaller branches of airways, and these smaller branches of airways of the bronchus is what we call the bronchioles, and the bronchioles will terminate at what we call the air spaces known as alveoli, and it is at these alveoli that gaseous exchange will take place. So this is generally the internal structure of our respiratory system, and it indicates from the entry points all the way to the gaseous exchange points. That is the alveoli region being covered by the capillary beds, as you can see here, that allows our deoxygenated blood to get oxygen and be oxygenated. So just a reminder is also that the deoxygenated blood is normally blue and the oxygenated blood is normally red or light red in color. So that's why you're seeing the variation of colors here. Then, now that we're moving towards the assessment, it's good to appreciate that for you to be good at respiratory system assessment, you need to know how the surface anatomy of this system looks like. So we've mentioned on the first photo, on the first diagram here, we've mentioned that our lungs have different lobes. And on the right lung, we said we have three lobes. So you have the first one here, the second one, and the third one. While on the left lung, we have only two lobes, the upper and the lower lobe. But in the middle or in between our lungs, we have our heart. So now, what are the demarcations on the chest, or what are the surface anatomy that you need to understand? So number one, you need to understand how to identify the lobes surface-wise. You need to understand how to locate the intercostal spaces. So like we have ICS1, this means intercostal space number 1. We have intercostal space number 2, intercostal space number 3, number 4, and number 5. And then the other part is how do we identify the bones? And here there's an identification of the clavicle, and the clavicle beneath it we get the first rib, the second rib, third rib, fourth rib, fifth rib, going all the way to the 12th rib, which is a floating rib, and somehow we call it that it's a false rib. So these are important things that you need to know. And the last important marking you need to know on the anterior side, that is the mid-clavicular line here. So the mid-clavicular line will help us in identifying key points when it comes to different techniques that we'll be using for the assessment of the respiratory system. So we have the mid-clavicular line here, and also at the midline, we have the midline, which helps us to divide the body into two equal parts. So the midline is also important when it comes to location and techniques of assessing the respiratory system. And from the back also, you need also to appreciate the the different lines. So we've mentioned the midline, which at the back will be at this point, and we've mentioned the mid-clavicular line, which is also be around the same point that was indicating on the anterior side. So these are very key for us to know. And after appreciating the surface anatomy at the back, it's also to remind us how do we locate the lungs or the lobes, and still reminding ourselves that the right has 3 lobes and the left has 2 lobes. So those are very key for us to know. Okay, so having understood our anatomy, and that is the internal organs, and having seen how the surface anatomy works, let's remind ourselves on the respiratory functions. So number one, we know that respiratory system measures on gaseous exchange, which acts as our capillary beds covering the gaseous exchange surfaces, that is the alveoli, and this is being facilitated by our respiration mechanisms, including inspiration and the expiration mechanisms. Secondly, we have filtration and moisturizing or humidification of air. It's proper to appreciate that when you're breathing in, our air needs to be free from any microorganism or foreign particles, and this is being facilitated by the filtration aspect. While the air at the same time is not supposed to be dry, but rather it's supposed to be humidified or moisturized so that you can have comfortable entry of air. Otherwise, dry air can be a bit damaging to our to our epithelium covering the respiratory surfaces. There's control of pH or homeostatic regulation of our pH. Respiration on itself is like a buffer mechanism where it helps us to regulate the pH, that is the acidity or alkalinity of our blood. So when our respirations are low, we are being told it produces the risk of having acidity or high carbon dioxide concentration in the blood. So to prevent this, we ensure that we have proper ventilation and proper gaseous exchange to to balance the pHs to be within the range. And of course, there is protection from any inhaled pathogens, but also from other pathogens existing in our body system, in that our nasal cavities are covered by a hair, and this hair is helping us to trap any foreign particles that are gaining entry to the cavity. And also our respiratory system has the goblet cells that are able to produce mucus, and the mucus is helping us not only to moisten but also to trap all these inhaled pathogens and foreign particles. And then we get the facts of vocalization and sound production being facilitated majorly by our larynx, and the larynx has cords. So the cords are the larynx, which are actually made of the true and the false chords. They play the role together to ensure that sound production is efficient, proper, and of the right tonations. So now we've understood the main introductory part. Let's see which techniques do we use to assess the respiratory system. So the steps can be abbreviated as IPPA, and this means you can use the first technique of inspection, followed by palpation, followed by percussion, and then we will finish with auscultation. So these are different techniques that we're going to focus on how to assess our respiratory system. Starting with the first technique of inspection. And like I said, the one thing you need to remember when you're going for this assessment is surface anatomy. So inspection uses a lot of the surface anatomy knowledge to be able to identify the different markings and how to inspect it. So on our diagram here, we need to appreciate first how do we locate the clavicle, and this is a guideline here you can see. Then we have the jugular notch here, very key when it comes to taking the deviations specifically for the sternum, and also when you want to check for the tracheal deviations. We have the sternal angle here, also known as the angle of Lewis, and then we have the costal margin. So the costal margins are very important because they will help us locate any change of the sternal angle, or so not sternal angle, sorry, but the subcostal angle. So In between the costal margin, there's an angle that has created here. So this angle is what we call the subcostal angle, which gets affected when we have changes in the diameter of our chest cavity, or if you have a change of diameters due to different illnesses in our body. So anyway, let's see, what do we focus on when we're inspecting, or rather when we're just looking on our respiratory area or on our chest? So number one, as you're inspecting, check for the respiratory rate. And checking the respiratory rate means you need to know how to count, and you need to count this for a complete cycle of 1 minute. So in the complete cycle of 1 minute, you're not just counting how many breaths are there per minute, but you're also identifying the depth. Is the rate deep? Is it shallow? You're also trying to establish the pattern. So is the respiration pattern irregular, or is it regular? How is it coming along? Then you want to look and see the deformities. Is there any presentation that shows some other kind of deformities? Are there like scoliosis? Okay. Is the patient presenting with some others like kyphosis? All these are deformities that are aligning with the vertebral column, but they have an effect on our respiratory functions. Then you're able to see shape change of the chest. And for shapes, you need to appreciate that apart from our normal chest shapes, you can also have abnormal chest shapes that are indicative of changes of diameters around our chest. And these shapes can come along like the barrel chest, the pigeon chest, and the funnel chest. All these are abnormal chest. But also you can have need to check on the symmetries in terms of chest movement. So if the patient is breathing in and out, a little bit check on how the symmetry is moving. Are the chest rising and falling at the same time on both sides, that is left and right? Is the chest maybe having one side not moving at the correct side and the other? And simply here, when you're doing symmetry check, you want to check it bilaterally. You're comparing both left and right side of your chest to ensure that the movement is symmetrical. And if the movement is not symmetrical, then how is the asymmetry? Okay. In the other areas, you need to check at skin appearances, identify scars, identify swellings, identify areas that have different colorization on the skin, and so on. And then with the subcostal angle, like I've said, this is an angle that you see at the costal margin. And this angle, like I said, changes if our client have different diseases. Check for special signs. So special signs are any other symptoms that you can identify away from our respiratory system demarcations. So you can maybe check for finger clubbing. This is a sign that shows the patient is having severe hypoxia or a severe lack of oxygen. You can check for cyanosis. Cyanosis, you can check it in the tongue. This will indicate for you, for example, if there's bluishness of the lips and bluishness of the tongue, this is indicative of cyanosis. And this is something that tells you our client could be having either severe lack of oxygen, or they could be having some cardiac conditions that are affecting our respiratory system at that particular time. So that's how inspection technique works. It's just the use of observation technique or observation to identify key aspects of our respiratory system, including respiratory rate, chest deformities, shapes, symmetries, skin appearance, subcostal angle changes, and any other special sign that you can pick. And the second technique is palpation, okay? And with palpation, it looks at just key things that you could not see when you are doing the inspection. So with palpation, number one, you need to first check for any areas that are indicative of pain and tenderness. So that's one of the targets that palpation will try to do, to try to identify pain sites or tender areas that could maybe show there's be an inflammation ongoing, or there could be some injury somewhere. So you want to identify those areas first. And then the other parts, the chest, the palpation will do is it will show you, it will help you confirm your chest symmetries. That is, you can confirm properly that the chest is expanding and relaxing at the same time, or is relaxing at the same levels. And in other areas, you can use palpation to check any changes in tactile parameters. By definition, tactile parameters is the vibrations that your chest will produce when a patient is vocalizing or when a patient is speaking. So a good number that you can tell them to do is to say 99. So when they say 99, you can feel the chest vibrations. And in this, you're comparing this bilaterally. So the same way you are inspecting bilaterally is the same way you'll be expected to compare even during palpations. So how do we handle the palpation technique? The palpation technique, you're advised to do it using regions of the thorax. So in this case, you can start with the upper. It's like in the first diagram here. You move to the mid-thorax, and then you finish with the costal margins before you move to the back. Okay? So the way you are handling the palpation is not similar to how you will handle, for example, percussion. When we arrive there, we'll be able to see that. But let's start first with the palpation when you're handling the upper thorax. So the upper thorax, mostly you're supposed to start at the upper region, at the jugular area here. So you will place your thumb near each other at the midline, or rather just place them at the midline in a way that they're almost touching each other or they're touching each other. And your patient should be placing their arms or their hands on the sides. So like you can observe on our client here. So when you place your thumbs together at the midline, you will now tell your patient to breathe in, okay, as deep as possible, and then breathe out. So as your client is breathing in, you want to check how the thumbs are moving away from each other. Remember, when your patient is breathing in, there is lung expansion that is taking place. Now, when this lung expansion is taking place, you expect your thumbs to be moving away from each other due to that expansion. So as they're moving away from each other, you want to observe how far are they moving from each other? Are they equally moving away from each other, or there's one side of your thumb that is not moving? So if there's one side of your thumb that is not moving, then it tells you that there's a possibility that there is low expansion on one side, and this is the side where the thumb is not moving away. So if it is not moving away, then it's telling you that could be there's something, either it's compressing the particular area of that lung, or there's an abnormality that is just hindering the expansion. So you start on the upper chest, and then you move at the mid chest, just below the nipple. You place or you grasp your hand on both sides. Try as much as possible and bring your thumbs together at the midline. And once you achieve that, you tell your patient to breathe in. When they breathe in, you expect the chest expansion to happen. And now here you're observing again how the thumbs are moving away from each other. So as they're moving away from each other from the midline, you observe the variations of the distance. If one side is moving but less distance, or they're moving at the same time, if they move at the same time, covering the same distance, this tells you that the chest is symmetrical, or rather the chest is moving at the proper symmetry, and so the expansion is normal. But also if the distance covered is too big, that could also be indicating to you about hyperventilation, which is an abnormality also. It's not a good sign because it happens in different illnesses. And once you're done with the mid-thorax, you can now move to the costal margin. So with the costal margin, you will place your hands on the chest and ensure the thumbs are also touching each other, but at the costal margins. So once that has happened, you tell your patient to breathe in and elucidate the expansion. So I want you to observe the difference that you are doing at the upper thorax, mid-thorax, and the costal area. So as the patient is breathing in, you observe your thumbs as they are moving away. Also, you need to be observing for the hands. So are your hands where you've placed them moving up at the same time and moving down at the same time, but you're also looking at the thumbs. Are they moving away, covering the same distance, or there's some parts that are not moving? So you want to check that. Check also the costal margin angle, the subcostal angle. Is it going in properly or is it moving away properly? You want to detect all this, and you can finish this by telling also the patient to vocalize the 99. Remember, here you have a good feel, okay? You have a good feel of the chest, or you have a good grasp of the chest and you're feeling. You can even feel for temperature changes. You expect the skin to feel warm, but if the skin feels cold or the skin feels variation in temperature variations, here you can still detect it. And like I said, you finish this with the back. So you will use the midline again, grasp your patient just below the scapulars, and you tell them to breathe in and observe the expansions. So the key marking that guides our palpation is the midline here. So let me just indicate this so that you can see. So the midline is very key for you. And this will show you the indication, the changes. Okay. So here's the technique. So like the way we are demonstrating. So this is more clear. So we've mentioned the subcostal angle. So as you can see, he's clearly created that. And then I will tell your patient to breathe in. When they breathe in, you observe the separation of your thumbs, that they're moving away from each other, and see if it's not normal separation. If one side is not moving, then it's indicative of an abnormality. Same thing with the back. So at the back, like I said, below the scapulars, you place your hands there, pull it together until the thumbs are touching each other, and then you tell the patient to breathe in and check on the expansion. So like you can see, this is before breathing in or before the inspiration, and after the inspiration, you can see now how the thumbs are moving away from each other. Now, this is our midline, but you're supposed to check the difference. So are they moving away from each other, covering the same distance, or one thumb is still at the same place? So if one thumb is at the same place, didn't move, didn't tend to respond to the inspiration, then this could be indicative of abnormalities or illnesses. Third technique is percussion technique. And with percussion technique, we're simply saying we are using a technique where we want to produce sound to check the lung fields. You are producing sound to check the lung fields. So here you will place your finger on a lung field, and with the lung field, you will tap on that finger using a tip of the other finger on the other hand, and you listen to that sound. So our targets here are the lung fields, and we'll be checking the lung fields bilaterally. So checking the lung fields bilaterally, you will see how to achieve that, but we will be being keen on observing the sounds. So the sounds that we expect is what we call the resonance, which is supposed to denote a normal lung sound. But also you want to check for dull notes, which is supposed to be indicative of any abnormal fields. And abnormality that comes from the dull sound could be tumors or illnesses like pneumonia. So now we've said that resonance note means normal field. But you need to know hyperresonance, where it means too much air is available in the fields, could be indicative of illnesses like emphysemas and pneumothoraxes. But now, how do we percuss our patient? So the percussion, just like the way in palpation we had a technique or we have steps, the percussion, will follow the same. So what happens is with percussion, you need to have points. Okay, so you'll have points. There are people who will indicate it in a continuous manner, like they just talk of point 1, point 2, point 3, point 4, point 5, point 6 in such a manner. Others will talk about point 1, point 1, point 2, point 2, like that. But it's still the same, provided you are understanding how the technique should move. So the percussion technique moves in a continuous way. You do not zigzag your movements. So we say that you will be checking the sounds bilaterally. So what do we mean bilaterally? We mean when you're checking the lung fields on the left side at this particular point, you also need to check on the right side at the same particular point so that you can compare the field or the sounds. So you're told when you do that, you can also use the mid-clavicular line for your assessment. You can use the mid-clavicular line to get good points. So when you start at point 1, you will tap your finger there and get to hear the sound at that particular field. And then you will move to the other side of the midline, no, not midline, sorry, on the mid-clavicular line, and listen to that sound and compare. Is the sound the same, or does one side produce resonance and the other side is producing dullness? If these sounds are not the same, then it will tell you the area where it has dullness, that is where the problem is. And then you move downwards at a different point, you check, move to the other side, compare now. So you can compare point 3 and 4 and see bilaterally how are the sounds. Are both resonant, or are we having dullness on one side and resonance on the other side, or are we having dullness on both sides? Now, when you're moving downwards, these are areas where we are targeting the lobes. So these points are not blind points. These points are points where we know we can access our lobes. And remember, we said our right lung has 3 lobes and our left lung has 2 lobes. So these are areas that when you are percussing, you are checking literally like all the areas of our lobes, or rather all the regions of our lobes. So it will give us like a bigger view or a bigger result in terms of coverage of our lobes. And by the time you are moving to point 7 and 8, you get to be accessing the pleural spaces. And these pleural spaces are areas or zones that are very prone to developing pleural effusion, or a condition where there's accumulation of fluids due to different illnesses or inflammatory processes. So that is very key for us to know. So this is percussion technique on the anterior side of our chest region. But always remember, after you are done with the after you're done with the anterior region, you need to move to the posterior, and you'll be percussing it in the same way. Point ones, like I was telling you, you can have point ones. You can name the upper areas point ones, or you can name 1, 2, 3, 4, 5. But this one has used the technique of equalization, that is point 1 and 1, 2 and 2, so that it's easy to just give results. So if you're moving from point 1, you will percuss there, then move to the same point on the other side, percuss, then move downwards like that until you maximize and finish with the pleural spaces at point 5. So this is to help you get comparative results, comparative lung fields and sounds, and be able to tell, is there a dull note, is it a resonance, and decide. All right, apologies for the noise. So let's pick up. So it said you can maintain same point numbering, or you can use continuous numbers. So like 1, 2, 3, 4, 5, like that, or you can maintain the same point numbering, provided you can bilaterally compare your lung fields and identify the correct notes, and then give a result or an analysis. Is it resonance or is it dull note? And finally, we got to see the auscultation technique. And with auscultation technique, we are saying here we use a stethoscope to listen to the lung fields. And in the lung fields, we will also listen to them bilaterally. So bilaterally means we will be checking on the right and comparing it on the left. And again, you are targeting breath sounds here. And like for the percussion, where we were targeting the notes, that is the dull or the resonance. Here we are targeting the breath sounds. Now the breath sounds are of 2 types. we have the vesicular sounds, which are also treated as the normal breath sounds. These vesicular sounds are said to give us an indication of clear air entry. There's no obstruction. There's proper ventilation for our patient. But when we talk about the abnormal sounds, we talk about examples like the bronchial sounds, the crackles, the roncas, wheezing, pleural rubs, and stridors. So all these are different abnormal sounds that can be produced when a patient has developed different abnormalities or conditions. So now let's go directly onto where will we place our stethoscope while auscultating our patient. So I want us to appreciate that with the lung sounds and using the stethoscope, our main lines that will guide us is the mid-clavicular line. As you can see on this diagram, it's properly shown on the number 1, 2, 3, and 4s. And yes, both at the front and the back. And then we will utilize the mid-axillary line. So the mid-clavicular line and the mid-axillary line are very important lines for us when we're auscultating our patient. And just like we've said, we are going to do this bilaterally. So bilaterally, you need to start at the first topmost of your lung, and that is the apex. Now, you are not doing this with a patient who is not indicating inspirations. So while you're auscultating, you need to tell your patient to breathe in, or rather to be taking deep breath while you're doing the auscultation. So you will place your stethoscope at point number 1. Tell your patient to breathe in, listen to the sounds, both while they're breathing in and when they're breathing out. So tell your patient, breathe in and then breathe out as you're listening to the sound. So is it a normal sound? Does it show you this clear entry of air and exit? And then you move to the other side of the lung apex and tell your patient to do the same. So breathing in, you listen to how the sound is. Breathe out, you listen to how the sound is changing. And then you move downwards to number 2. Remember, this movement is also continuous. You don't zigzag your patient. You have to move downwards, continuous, number 2. Tell your patient to do the same all the way until you're done with point 6. But now, like I said again, these points are supposed to help you make sure you have accessed all the lobes of your lungs. It's supposed to help you access all the lobes of your lungs. And the lobes of your lungs are on the right, you have 3 lobes, on the left, you have 2 lobes. And you want to maximize it until you access the pleural spaces, which are prone into developing pleural effusion, to ensure that those spaces are also clear, they're not filled up with any fluid, or they're not filled up with any tumors or masses. And once you're done with the anterior side, you move to the posterior side and observe the same. Observe your line, mid-clavicular line, and then you will now use the mid-axillary line to check for the sounds. So you get your demarcated points there, number 1s, 2s, 3, 4, 5, 6, and 7. So by the time you're done, you have exhaustively checked on the fields, or you've exhaustively explored the lobes and seen the different sounds that can be produced by the lung during inspiration and expiration. And this will be telling us or indicating us different abnormalities that gets to be elucidated by the different signs or sounds that are produced by our breath. That marks the end of our class on how to assess our respiratory system to help us identify the different conditions or illnesses that can affect our respiratory organs. So if you like content such as this, remember to like, comment, share, and subscribe, and click on the notification button so that you can be notified when we post these coming classes. Thank you very much, and see you in our next class. Bye bye.